My name is Martin Voss. I'm a GU medical oncologist at Memorial Sloan Kettering Cancer Center in New York. And I am delighted to speak to you today. Thank you to the organizing committee for inviting me to give this talk, Lessons from COVID-19, Evolution of Clinical Practice for Systemic Therapy and Clinical Research. Here are my disclosures. And I'm going to give a brief background on what we know and have come to learn through the past few months about COVID-19 outcomes as they pertain to patients with cancers. Early in the pandemic and through the ensuing months, we have come to learn a great deal about how a cancer diagnosis affects a patient's outcome once they acquire COVID-19. And there was an early signal that has since then been confirmed, initially through cohort studies from China, later Europe, and now more recently also from the United States and Europe, that patients with cancer diagnosis are at increased risk for dying from COVID-19. You see here a summary of several cohorts that have been reported over the years, and there's some variability as to how these are made up, which probably speaks to a difference in mortality, but they clearly send a signal that there's an increased risk of dying from COVID-19. This is data that was recently presented at ESMO. This is one of the largest registries, a European effort called the UK Coronavirus Cancer Monitoring Project, which has included not only cancer patients, but also non-cancer patients that can provide a backbone for comparison here. And you can see on the figure here on the left that the 30-day mortality is significantly higher for patients who have a history or of prior or current cancer than it is for patients with no cancer. And if we look over on the right, then we get the sense that this risk is increased substantially, particularly in patients diagnosed with cancer at a younger age, whereas the worst overall outcomes are seen in the elderly. Some of this may be explained not necessarily by the patient's cancer course, but also by the fact that a patient with history of cancer are also more likely to carry certain comorbidities that we know associate with adverse outcomes to COVID-19, such as chronic pulmonary disease, cardiovascular disease, and such. And that was also shown by the UKCCCMP collaborators in their recent presentation. But what about cancer treatments and COVID outcome? Early on, there was a concern that certain cancer therapies may confer an increased risk for adverse outcomes with COVID-19, more so than other therapies. On the left-hand side here, you see data from China, a multi-center cohort that was reported fairly early, and seemed to suggest that immunotherapies could increase the risk for adverse outcomes due to their pro-inflammatory effects. And even data from our own center here at Sloan Kettering in New York raised concerns over checkpoint inhibitor therapy early on. It's important to keep in mind that these were very heterogeneous cohorts, and it was difficult to control for certain factors such as cancer type of treatment delivered and such. And we have since then learned that we have to take these early data with a grain of salt. At the time, however, they raised concern, and here are three examples of papers that were published fairly early in the pandemic and provided expert advice on management for patients with genitourinary malignancies. And I have copied out of those the recommendations for metastatic kidney cancer. And you see that there was a concern over the use of immunotherapy, maybe in part due to the data that we just went over, but in part also due to the fact that IO therapies require inpatient encounters for intravenous administration. And these authors here separately all suggested to consider using kinase inhibitor therapy and the combination of TKI plus checkpoint inhibitors over IO doublets. Since then, we have learned more, and with larger cohorts, we have seen that the initial concerns over immunotherapy may have been exaggerated. You see here data from the COVID-19 and Cancer Consortium, a large registry effort in the United States that presented updates at ESMO also, but had already published a large paper in Lancet. And here, there was no clear association with any particular type of therapy and adverse COVID-19 outcomes. There was an update that was published to the UK CCCMP data early on that also found no such associations. And here's the most recent and largest data set presented from ESMO this year, 1,600 cancer patients on active or recent therapy, breaking down the different treatment types and comparing them to patients with a cancer diagnosis who had not received systemic therapy. And there was no significant association with adverse COVID-19 outcomes in immunotherapy, chemotherapy, or targeted therapy. It seemed that there's an adverse signal for chemo-IO combinations. However, that is fortunately not something we have to consider for our kidney cancer patients pertinent to this presentation. What seems the best way to approach the issue, for future, and hopefully with more data, we will be able to address these questions, is to look at these things separately by cancer type. Here's an example for a lung cancer cohort from our own institution that was published in Annals of Oncology recently. And here the authors were able to show that for one particular cancer, different treatment types, including IO therapy, did not seem to associate with adverse outcomes such as hospitalization, ICU stay and intubation, or COVID-19 related death. So my bottom line, interpreting the data as it stands today, is our patients are at increased risk for adverse outcomes from COVID-19 due to the fact that they have a diagnosis and history of cancer. It's not clear to me that the cancer treatment, particularly not the treatments that we administer to kidney cancer patients in the advanced setting, add to that risk. I think that's important for us to keep in mind as we plan our care models. Now, what are the lessons learned from March onwards? And I can speak a little bit to our experience here. I practice in New York City, and certainly, March through May was a whirlwind for us in terms of rapidly changing our practice. And we've come a long way, and we've learned a lot in the process. I want to speak to that a little bit. Certainly, despite of all the concerns over adverse COVID outcomes, cancer hasn't taken a break. But if you look at the data and the new visits, cancer diagnoses, as you see it here and such, one had the sense that everything stood still for a little bit in March and April before things picked up again. Here you see visit volumes in the genitourinary oncology section here at Sloan Kettering, and going through this, this impressively demonstrates is, for one, how we had a sharp drop in late March, early April in overall volume. But if you then look at the breakdown as to how much of the patient encounters are in person versus remotely, you can see that in-person visits, which are color-coded in this dark red brownish color, dropped from over 80–90% to minuscule amounts. In the beginning, we made up for that in large, highlighted in light blue here, through phone encounters, and that reflects the fact that we weren't set up yet for telemedicine with video encounters, which became our routine mode of communication with the patient shortly thereafter. So throughout May and June, we really vamped up our capacity of doing video encounters, and this still is a large proportion of what we do today. If you look at the September data here, you can see that there's equal amounts of in-person and video visits, plus some phone sprinkled in. So how does one make this all work? Well, for one, I do think that video encounters are really the key to keeping patients, particularly those on active therapy, connected with their care team in a safe way. Finding the right platform that works for you is important, and obviously we don't all have the choice ourselves. It's our center that negotiates these things, but I was very involved in our hospital's search for the optimal platform, and what we've come to learn is that there's often a disagreement as to what's best in between the software developers and the clinicians who actually have to make these products work for our patients. In my opinion, simplicity is worth more than we can emphasize here. There are very simple questions that we have come to appreciate through the months. If you coordinate a busy clinic of 20, 30 video visits in one day, it's important that the patient is able to connect with you seamlessly, does not need to download an application or make a profile, but that a simple text message that then turns into a video visit at the click of a link is ideal. It should be the care team that initiates the call, not the patient. That way, we can try to keep our pace in clinic. And then there are certain features that have come to be very important. Screen sharing can be incredibly important when you talk to patients. Multi-caller connection so that we can dial in a family member or a nurse, a subspecialist, or the fellows that work with us in clinic. We quickly saw, particularly here in the New York City area, that a lot of patients through the pandemic chose to change location. A lot of people moved away from New York City when numbers were staggering here, and we had to learn that a lot of the patients that were under our care had moved to other states, and it took a long time for us to figure out how to make that work. There are certain considerations around licensure, and every single state has had their own approach to making the emergency state work for their patients. On the right-hand side at the bottom here, you see something that I've copy-pasted from our intranet, and our legal team and our administrators have provided tools that update in real time and help to support us and tell us what the requirements are for each state. So if a patient tells me that they have moved to Georgia, I can find out this way. Is there a requirement for me to apply for a license waiver? Is there a possibility to get a temporary license and such? And then separate to that are the CMS requirements for reimbursements for visits, and that is more of an institutional consideration and for the individual providers. Nonetheless, really does shape how we do our remote care. Patient resources are incredibly important. The patients are at home and they yearn for direct interaction with us. They are trying to make sense of all this, and our website has seen many, many iterations through the months, as I'm sure have many of your own institutions. And the more information we can make available to our patients, be it video clips or downloadable PDFs, I think make all the difference. So how do we make the actual treatments work? For kidney cancer patients, we give oral medications and IV treatments, and we have adjusted our approach quite a bit since March. A lot of it is about limiting exposure risk, particularly when the numbers were so high in New York. We really tried to limit exposure of patients. I think the worst case scenario was a patient who would have come in for treatment, and that day we determined that the patient, for whatever reason, was not safe to receive the therapy, be it laboratory abnormalities or clinical toxicities that were assessed. Now, this patient had left their home, driven into the city, coming through our lobby or waiting room or lab and so forth, only to be turned away and drive back home. So very quickly we adapted our workflows to avoid that type scenario. So the remote calls that we make to check in on our patients before their treatments are made on separate days in their treatment, ideally a day or two before, so that we don't find out the day off that a patient is not safe to receive their therapy. Same thing, we dissociate lab and treatment visits. We try to have the patients do their labs a few days before to avoid them having to learn that they're not going to be treated that day. There are several services that work with big private lab companies such as LabCorp and offer in-house phlebotomy. So we have made use of that quite a bit. And then it is important to stay on top of the providers and make sure that treatment orders go in early, ideally the day before, so that patients don't spend time in the building waiting for their therapies to be mixed before it can be administered. Dosing intervals are key and have been discussed much. The two IV drugs that we give the most are on label are nivolumab, either as single agent or in combination with ipilimumab, or pembrolizumab in combination with axitinib. And both of these, as you all well know, can be given on different intervals. The pembrolizumab label extension couldn't have come at a better time. At the height of the pandemic, we were able to switch treatment intervals for many of our patients and limit the number of trips that we make per month. How about kinase inhibitor therapy? So we have learned that oral agents, the way we've given them for many years, can actually be managed with less frequent visits to the office. Here's a snapshot image taken from a video call where you can see that you can assess a patient, at least to some extent, for hand-foot syndrome on a video call by having them show their hands and feet with the camera on their smartphones. Patients typically are encouraged to keep a blood pressure log while they're on kinase inhibitor therapy, and this is something they can share with us remotely. They take a picture of the log on their phones, they fax it to us if they have a fax, they send it through our patient portal, and we can review the blood pressure logs that they've kept at home for management from afar. And we are shipping medication quite a bit more than we used to limit visits to the pharmacy that patients take. Treatment choice is a big one. So the biggest choice that has been discussed, in the context of all this is whether or not IO versus IO-TKI combinations should be preferred. You can see here the NCCN guidelines that list, both such options in the first-line setting as preferred: ipilimumab, nivolumab, or axitinib, pembrolizumab. And I, on the right-hand side, have pasted the same figure that I showed before. The most current data, such as presented, only a few weeks ago, does not suggest that there is an increase in adverse outcomes due to immunotherapy. So I do not believe that mechanistically, by mechanism of action, we should be overly concerned about the one or more inclined towards the other regimen. What is relevant, and I think it matters where you are and what the case numbers are at the time that you're making the decision with the patient, is how prevalent the virus is and how much risk any patient takes as they get into their car, drive to their appointments, sit in a waiting room and such. I would argue that we have introduced many mechanisms of protection that we did not have in March and April that can ascertain that IV therapy in our treatment suites, at least here at our center, can be given safely. So to me, shared decision-making has become more important than ever. We have to be sure that our patients are comfortable with the treatment programs we provide. But I do not think that we should categorically shy away from one treatment regimen and lean towards the other just based on mechanism of action and COVID-19. What about education? So our trainees, the residents, fellows, and nurses and nurse practitioners in training were certainly hit hard by this pandemic in that they lost access to teaching, and it took a while for us to get that thing figured out again. I think there is a balance here that we have to keep, in that we are responsible also in protecting their safety while we provide a teaching environment for them. However, we can't deprive them of the opportunity to learn and interact with our patients. I've pasted this little icon here on the right-hand side. This is what the icon that many virtual platforms use to dial in a third caller. I think that can be incredibly helpful. Bringing in a trainee while you are talking to the patient, having them participate in telemedicine, not just make phone calls. So, and then lastly, and I do this frequently in my own practices, in between patients, as we talk to our fellows who are now remote from us, we can use platforms like Zoom and Microsoft Teams and so forth to share slide decks with them, show them publications, discuss the patients remotely. How about clinical research? So we need to work with our sponsors and have been, and For the most part, I feel this has been a positive experience. Sponsors have introduced various mechanisms to give more flexibility in our clinical research. Protocol amendments have been introduced, and we need to work with our sponsors to critically re-review protocols that were written prior to the pandemic and could still be adjusted to make for more flexible schedules and cut out superfluous visits that may put patients at risk unnecessarily. Remote monitoring for the CROs and sponsor monitors that we work with had to be introduced at all sites quickly. And then some of the very hands-on questions: how do we get the drug to the patients for oral investigational agents? Our research pharmacy here very quickly moved towards shipping medication to the patients where they usually would come pick it up here at the site. The consent process is something that we took a while to figure out. We now have an e-consent process, and I've copy-pasted that from our website here. So there's a login that investigators use, and then you can pull up the protocol, put in the patient's MRN, which takes you to a website that you can review with the patient. So the patient reviews this at home while you look at it in your office. We do this through screen sharing, either on WebEx or Zoom, and you scroll through the various sections of the informed consent form, and then ultimately, find a way to share your cursor with the patient, have them take over control of the mouse, and have them sign the consent on your screen before you do it. It's somewhat tedious, but once figure it out, patients are so grateful to be able to do this from the comfort of their home. It is important, and I would stress that I think every patient who starts on a new therapy, certainly on an investigational agent, must be evaluated in person before they treat. So my practice here, and this is what most of us do, is we do a lot of the consent discussions, review of the protocol, and maybe even the signatures, as I show you here, remotely, and then for the actual screening visit in cycle 1, day 1, we see the patient in person. The last section that I'm going to show you quickly is managing COVID-19 itself. We all had to learn how to do that. And it's important to stress that the majority of patients are actually at home and not requiring hospital stay or ICU level care. So our center has worked tirelessly to optimize the process that we have. And we have an outpatient cohort program where patients who are diagnosed with COVID-19 in our system actually reached out to by nurses and mid-level practitioners who do an assessment, and the patients then, through a questionnaire that they fill out each day, stay in touch with that team. And if there are certain alarm bells that go off due to the clicks that the patient makes during that daily questionnaire, they get another call from the management team that can advise them on next steps. Do they have to come to the hospital? Do they have to consider certain measures at home and so forth? For patients that we discharged from the hospital from one of our COVID floors, at some point we introduced supplying home oxygen monitors, so that could feed into this monitoring system also. And you can see here a dashboard that the cohort management team within MSK would use to follow a patient at home while they were recording at home their SpO2, heart rate, and the questionnaire replies on the daily check-in. So I'm going to summarize here. It's relevant for us to be aware that our patients are at increased risk for adverse COVID-19 outcomes due to the fact that they carry a history of cancer. But it is important to keep in mind that competing with this risk for adverse outcomes with COVID-19, if they were to acquire it, is the adverse outcomes that they could face from their cancers by receiving suboptimal care, in 2020. We have learned through the months that the therapies that we typically give for advanced kidney cancer, namely kinase inhibitors, IO agents, and the combinations, can be administered safely. This does require person-to-person interaction, but we can try to leverage the tools that we have to limit exposure best we can, and we must always integrate what we know about the current state of the virus and the location that we're in to weigh those risks and make decisions on when, how, and by which means we see and treat our patients. Novel tools can not only facilitate that, but also education, as well as clinical research. And just as we adjusted our clinical practice routinely, we must adjust clinical research as we plan it moving forward, including adaptation of considerations in clinical trial protocols that keep the patient's safety in mind. With that, I would like to thank you for your kind attention. I am also thankful to folks here within MSKCC that provided me some information for my slide deck, including our clinical research management team that has worked tirelessly to make this all happen, but also the Hospital Incidence Command team within Sloan Kettering. I'm very thankful to our patients for all the courage that they've shown and the patients that they've demonstrated through these very difficult months. To all of you, I hope you are well and that you stay safe. And I'm looking forward to the panel discussion for this session.